This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is the Group Room, making our 15th appearance at ASCO and one of our very best. Joining me now is Dr. David Quinn, Medical Director of the Norris Cancer Hospital, co-leader of the Genitourinary Cancer Program for the USC Norris Comprehensive Cancer Center, head section of Genitourinary Medical Oncology, and Associate Professor of Medicine in the Division of Cancer Medicine and Blood Diseases at the Keck School of Medicine. You are the Group Room's main guy for GU cancers. And today we're going to talk about prostate cancer.
As we sit here in 2013, we've had a series of drugs approved, and we've talked about a lot of them. We now have, within the last 5 years, a novel chemotherapy, cabazitaxel called Gevtana, immunotherapy, Sipuleucel-T called Provenge, and then two novel hormonal drugs, one called abiraterone, which is Zytiga, and the other called enzalutamide, which is Xtandi. And then we have new news. We have a drug just approved in the last week, which the FDA has given a new classification to. It's a unique drug, and it's a skeletal agent that targets bone metastases in prostate cancer, and it has two very important effects, and that's palliation. So it improves pain and delays progression of pain, but significantly it improves survival. And this is the first time we've been able to demonstrate this. So this is very exciting. It's a drug that will be given usually in nuclear medicine departments rather than in oncology infusion centres, but also by some radiation oncologists. And so that's very interesting, and it comes as really drug number 5 that improves survival.
I'd love for you to expand on it, because when I learned about the compound, I was fascinated by the way in which this drug is targeted and how it's absorbed.
I'm going to take you back to high school chemistry, and there are alkali earth metals that sit on one side of the periodic table, and one of them is calcium, which is very important for bone. But there are some other things over there that we've used over the years, particularly strontium, to carry radiation into bone. So we have strontium therapy.
It's radium, right?
Yes, yeah, that's very good. So radium's at the bottom. The development of radium-223 in Scandinavia at the Norwegian Radium Institute by Doctors Nilsson and Brulard really is a translational model for the way we should develop new drugs. They developed this drug, they worked out how it went into bone when bone turned over, and they produced some very elegant work over now more than a decade to bring this forward. And then when it came to a crucial time about 5 years ago, there was a spin-off company made called Algeta, and they teamed up with an international pharma company, Bayer, to move forward. But they'd already launched the F.R.A.C.P study, and we saw data from this, first 18 months ago at GU ASCO and also ESMO. And then the data has evolved and now has been through the FDA and reached approval. Now, it's a very interesting therapy because as your bone turns over, it absorbs these atoms like calcium, but also strontium and radium. And the radium is concentrated into the area where the bone metastases are, and the bone turns over, and the prostate cancer cells in bone sit right next to this. There's another little piece to this, and most of the radiation that we do is actually beta emission, which produces, if you put a beta particle into bone, which is like what strontium does, you get a radiation of the bone marrow. And one of the problems with therapies like strontium is that you drop the blood counts down and produce all sorts of problems. Well, radium is an alpha emitter, and alpha emitters are they're very large relative to beta emitters, but also they produce a high level of radiation over a short span. So they don't tend to dose the marrow with radiation. And the other thing is that's important technically, standard radiation produces single breaks in DNA. So there's two strands of DNA, and if the other strand is intact, you can actually, the DNA can repair itself in the cancer cell. What happens with radium and the alpha emission is it produces double-stranded breaks, which are often lethal to those cancer cells and very good for the patient.
Finally, that there's a therapy that's really meant to just target that area of metastases is fantastic.
I think it's very exciting. We'll be moving forward with studies in bone metastases in patients with breast cancer. There are also plans to look at lung cancer, which also goes to bone, and some other cancers that perhaps don't so commonly go to bone, but where that niche can be targeted. So I think we have the dawning of an age of a new therapeutic, and that's very exciting.
Does this mean that when you look at what's available now with these really growing number of treatments for prostate cancer, how do you decide of what's available, what's correct for individual patients?
That's a really good question. So most of our advances have been in what we call the castration-resistant prostate cancer space. So these are men who have had hormone therapy as a first standard and then have progressed after that. And these patients used to do really badly, like they'd lived less than a year before. Now they're doing much better. Now, the way we decide is based on a number of things. And it will be distribution of cancer, whether they have bone pain or not, that's significant, and also what their performance status is. So if a man can't get out of bed, then unfortunately that means that even if he hasn't had these drugs, then he may not do so well. So if we start at the beginning, usually men are asymptomatic or have minimal symptoms where they don't need much medication for pain. And that's the indication to use one of three drugs. And traditionally we've given chemotherapy with docetaxel to those patients where there is a survival advantage, but you get the side effects of chemotherapy. Subsequently, we had choice with giving immunotherapy with syphilis LT. The IMPACT trial was done in that setting. And more recently, abiraterone has shown marked disease stabilisation over many months, in fact an average of more than a year. And so we're left with making a decision at that point as to which one we give. And usually I like to, when it's appropriate, expose patients to as many agents as possible, because at the moment I don't have a way of predicting who will respond. And the duration of effect varies. So immunotherapy, you seem to need to get in early and let the immune response develop in the patients over as long as possible. Whereas we generally reserve chemotherapy now for patients who are symptomatic or are progressing rapidly after earlier drugs. So usually the sequence now is to give to look at syphilis LT, Provenge first, and if that's not suitable, look at either abiraterone, a novel hormone therapy, or chemotherapy with docetaxel.
With the now addition of a drug that can target bone metastases, can that be used in combination with these other compounds?
We potentially, but we don't know. And at this conference we saw a phase 1 study combining docetaxel chemotherapy with radium-223. I don't think that's ready for prime time as yet. We can't give full doses of both, and Memorial Sloan Kettering are going to test in a 2-arm phase 2 study a full dose of docetaxel at 75 and then docetaxel at 60 with radium to see what differences in toxicity we see and potentially some outcomes as well. But radium and docetaxel are really reserved for patients who are symptomatic. So if you have symptomatic bone metastases, then you'd look at those two. If you have visceral metastases, say in your liver, that are significant, then the radium, it doesn't target the liver at all. So we're still going to use chemotherapy with docetaxel.
Thank you so very much. Dr. David Quinn, Medical Director of the Norris Cancer Hospital, co-leader of the Genitourinary Cancer Program for the USC Norris Comprehensive Cancer Center, head section of Genitourinary Medical Oncology and Associate Professor of Medicine in the Division of Cancer Medicine and Blood Diseases at the Keck School of Medicine.
Thank you very much, Selma.
Thank you, Dr. Quinn.